Okay, Peter, I'm going to start in like 5 seconds.
Yeah.
So,
Recording in progress.
Welcome this evening to the ISOLS 9th webinar. It's an exciting seminar we have tonight, being chaired by Manish Agarwal with a world panel. I'll hand it over to Manish to continue, and we'll have some further words at the end. Thank you. Welcome.
Well, the entire focus of this webinar is on local recurrence, which presents after limb salvage surgery without metastatic disease. And we'll try to solve some of the dilemmas that we face, all of us face as surgeons. So we're going to have 3 short talks of 10 minutes each, beginning with Bhavin Jhankaria, who's going to speak to us on imaging in a scenario of local recurrence. Over to you, Bhavin.
Okay. So you're able to see the screen?
Yes.
That's a mouthful of a topic, but the basic aim today is to look at imaging following limb salvage surgery for suspected recurrence, but the focus is really going to be on imaging as method, since these situations are the most difficult to evaluate an image. And the modalities that we have, and we shouldn't discount the plain X-ray, it really makes a difference in the presence of metal. Then we use MR with metal artifact reduction sequences, but there's been no major study on this particular topic. The same goes for CT. We use Mars CT quite a bit. Ultrasound with color Doppler also helps, and I'll show one example of that, as does PET CT. Now, Mars MR, and many of you would have seen this, we use special sequences with some high bandwidth and some technical jugglery so that we can reduce the artifact. Now, this is a regular post metal on metal THR, and you can see that using the Mars MR, we can actually reduce the artifact significantly. See the collection here. There is a challenge with the bulkier metal that we have with the megaprosthesis or the endoprosthesis, but even here you can see this recurrent tumor. It's not very well seen on the routine MR, that's the SAG and the axial, but once we've used those special sequences, we can actually see the margins of the tumor quite well. So this is the one thing that we do, and we do the same with CT as well, where we use monoenergetic imaging, some iterative reconstruction. So again, a lot of jugglery there. And then we can reduce the artifacts significantly. So here we've used a high KEV with the iterative reconstruction, and you add both of those, and you can see there's really no artifact on this in this patient with the THR as compared to the other sequences here. And so let's just jump into the cases. About 4 of them. This is a patient where we've used Mars MR and Mars CT, a 24-year-old with osteosarcoma operated 3 years ago and now has a growing swelling. And in most of these patients, I don't have the x-rays, but I've reconstructed them from the CT scan data. So that's the frontal and the lateral. And clearly we can see a bone-forming lesion here. So we know that there's a recurrence. In this case, the MR didn't do really well. We can see the tumor. We can see the margins reasonably well. We know that there's a bright area here on the stir. But because of the osteoid, the CT actually does well. We're able to see the superior and inferior margins. There's very little artifact that we see from the metal. And on the coronal as well, the entire tumor is well seen. Now, we didn't give contrast here for the angiogram because the neurovascular bundle in any case seemed quite far away, but that's something that we do, and I'll share a case as well. So in this particular situation, Mars CT seemed a little better because it had fewer artifacts, but that's also because we didn't really have to bother about the soft tissue contrast because of the osteoid that was there. But if you look at another case, right, where the soft tissue contrast matters, then it changes things. So now scan plane orientation matters, the amount of metal matters, the bulk of metal would matter. So here is another 56-year-old man operated for chondrosarcoma in Jan, grade 1, 2, but has now come with a recurrent swelling. And again, these are the reconstructed X-ray-like images from the CT. Now, when we look at the MR images at the site of the headpiece here, then there's a lot of artifact, but you're still able to see the recurrent tumor because of the high contrast of the cartilage. And we move just a little bit away from there, and we can see the entire tumor really well on the MR. Whereas on the CT, while the artifacts are less, because the contrast to noise of a cartilage tumor is much less, we can see these foci of cartilage, but the tumor margins are so much better seen on the MR than on the CT. Though the CT does show the involvement of the posterior margin of the glenoid that much better. And this is a new finding that would, I guess, impact treatment as well. So this is another situation where we have the MR, we have the CT, and in this case, both are complementary, but the MR here gives us a lot of information because of the high contrast to noise, where CT allows us to see its margins with the rest of the bones, etc. So Mars MR has better soft tissue contrast when we can actually see the tumor. MR is not always needed. So here's a patient, 37-year-old, operated for a cartilage tumor in 2001, but then had chondrosarcoma in 2017, now comes with a popliteal fossa mass, and that's the mass here on these X-ray-like images. One interesting situation, same data set, the sagittal image has very few artifacts. You can see the tumor really well, whereas on the axial, and it's the same data set, we have more artifacts. So sometimes the sagittal and the coronal have fewer artifacts than the axial. Here we did the angiogram, and you can see it very well reconstructed despite the metal and the sagittal image. And then you can trace the vessel on the axial, and clearly the mass is adherent to, but is not encasing the artery. Here, ultrasound helps. So that's the tumor, and we've reoriented this. That's the metal lying here. We can then see the relationship of the tumor with the artery and the vein, and they're just adherent to, but they're not fully involving, or the mass is not involving the vessel. So angiography works better on Mars CT. To remember that metal doesn't affect the FDG component. So here's the last case, a 48-year-old lady operated for giant cell tumor in 2006, eventually developed a sarcoma, now has pain. So 2017, when we did the PET, we found this nodule here, which I biopsied, and it turned out to be sarcoma. She was treated as osteosarcoma and now has come back with this bone-forming lesion posteriorly. And you can see on the PET that it has high uptake, and the metal doesn't affect the activity of the PET. That you will see anyway. In fact, the metal doesn't throw any artifact on the FDG image itself. But the CT component and the fused image, obviously, there'll be artifacts from the metal. And I was just discussing with Manish, we are not able to do Mars or metal artifact reduction on the CT component of the PET CT, because that would be really good, though. But here the MR worked. I mean, you can see the tumor margins really well. So we know that that's a recurrent lesion. In fact, the CT shows the osteoid component, but again, the soft tissue contrast of the MR is superior. And then we just biopsied this, and it showed recurrent osteosarcoma. So it's all a mix and match. Mars CT has fewer artifacts, Mars MR has better soft tissue contrast, and angiography is better with Mars CT. Ultrasound color Doppler can show the lesion well in most instances, including the vessels, except that it's really operator dependent, and so that becomes a challenge. And FDG PET is not affected by the metal as far as the FDG or the PET component is concerned. And so basically the imaging has to be tailored to the situation, the area, the questions to be answered, the extent of metal, and invariably, it's sometimes you only know after the scan is done whether that modality is working or not. And generally we need to do at least two modalities. So if we do an MR with Mars, it's a good idea to do a Mars CT. If you're doing just the CT for the vessels, maybe it's a good idea to also add an ultrasound color Doppler. It just increases our confidence levels to have two modalities together for complementary information. So that was the idea, basically to show how in real life, we're using all these modalities that we have with us to look at people who have these large endoprosthesis and megaprosthesis. So I'm going to stop sharing here, and Manish, take it ahead. Manish, you're muted.
You're on mute, Manish.
Yeah, so we'll go to Peter Choong now to give us some guidelines on how to manage local recurrence in the extremities. Dr. Choong, you are muted, so again, you will need to unmute yourself.
Yep, I'm just trying to share the screen here. Hang on a second. Okay. Can you see that?
Yes, we can see it.
Great. I'll still just use the slideshow. So thank you very much for the invitation to present. When Manish first asked me about managing locally recurrent sarcoma of bone, I immediately reflected on the fact that we don't do many of these. They're not very common, and as such, it really was a challenge. And the question was, can I add any planning tips or techniques to this? And that seemed to suggest that I do it really frequently and therefore had a terrible recurrence rate. But in fact, when I thought about it, it really was one of a question of philosophy of how you manage this. And I suspect for each of us that would be somewhat different. So when I consider managing locally recurrent bone sarcomas, I think of three things. First of all, the type of sarcoma, and the type of sarcoma really, although we deal with so many different types of sarcomas and tumors, the three big ones that we think about are osteosarcoma and Ewing's because of the chemotherapeutic and potentially radiotherapeutic modalities we might use, and then chondrosarcoma because it's so easy to see that, and it comes in forms that are very heterogeneous and taxes our thinking about how we should manage it. Then, of course, there's the types of treatment that they've had. Has the recurrence occurred during chemotherapy? Was it resistant to chemotherapy? Did it have a good response initially? Have we given the area radiotherapy? Because that has a huge impact on how we might manage it. And of course, understanding the sorts of surgery that implied, was this very good margin surgery, which then got a recurrence, which may indicate perhaps a far more aggressive tumor, or perhaps even a local manifestation of systemic disease, versus surgery that was just badly performed with poor margins. Then there are three sorts of recurrences I thought about. One was just the true local recurrence. One was a local recurrence that occurred in the setting of metastatic disease, and finally, osseous metastases. So I've left osseous metastases out in the discussion today because I think that's a different category altogether and deserves a discussion on its own. So by way of background, metastasis from bone sarcoma sit somewhere between 30 or 40% of our patients. Bone metastasis that might confuse us from time to time accounts for about 10%. But true local recurrent disease is less than 10%, sits somewhere between 5 and 10. What we do know in say, Ewing's and osteosarcoma is that if you were to get a local recurrence, your 5-year survival sits somewhere between 13 and 40%, and your event-free survival obviously a lot less than that, between about 5 and 25%. So the key thing really is that treatment is challenging. We understand that there's no standard second-line therapies, and whenever you ask your medical oncologist, they will talk as if there's always done it this way or that way. But when you look through the literature, there is really no standard approach, and it really is quite empirical. What we do know, though, is complete surgical removal is pivotal to having good local control of disease. And if ever there was an opportunity to cure, then it can only occur with a complete surgical removal. And that's the very first philosophical point to make, I guess. In managing local recurrence, I think avoiding it in the first instance, and I would like to reflect on this particular paper by Piero Picci, published in JCO 1994 when I was at Mayo. And it has stuck to me ever since, because I think this is one of the most important papers actually around. it predicts that recurrence is related to response to neoadjuvant chemotherapy as well as the adequacy of margins. And so Piero and the team developed this matrix where if, for example, you were a good responder and had adequate margins and we standardized against that, then if you were a poor responder with good surgical margins, you had a 3 times higher risk of local recurrence. If, on the other hand, you were a good responder and you had bad surgical margins, you had 5 times the risk of local recurrence. And if you had both a poor responder and the surgery was bad, you had a 50 times risk of local recurrence. So that said a lot about how you could predict to the patient perhaps what you should do, amputation or limb salvage. And also prognostically, it tells you what we're up against, whether we should choose more aggressive margins, that is closer to the patient tumor, or more conservative margins where it's much wider. So the indications for surgery when you get a local recurrence, well, you can have curative or palliative. Obviously curative if it's local recurrence alone, or in an oligometastatic situation where you truly believe you can control it in late disease. And if you were to attempt curative and you were successful at that, then 60% 5-year survival for that. What they found in certain studies was that there was no difference whether you use chemotherapy or not in the setting of local recurrence. Bachi had recommended amputation at the same time that Nathan suggested limb-sparing surgery, and when comparative studies were done, there was actually no difference in overall survival, whether you did amputation or limb-sparing surgery. And I guess it would be a question of whether the surgeon thought limb-sparing surgery was feasible or not. Then there's palliative, which is the obvious one when you get local recurrence and metastasis, because it's quite dismal. Then your 5-year survival drops to about 10%. Either way, you can choose oncologic surgical margins then, and you do that for symptomatic relief, fungation, and that can be achieved through amputation or limb-sparing surgery, or you can perform positive margin surgery. And once again, it is for a palliative extent, symptomatic relief, fungation. You can once again either use amputation or limb-sparing surgery, but this really is a short-term solution because you don't want to create another problem for the patient with positive margin surgery, and that is to create a fungating wound. Here's an example of the sorts of dilemmas we all would face. This young man, he's 39 now, I saw him last week. About 2 years ago, he had his first recurrence for Ewing sarcoma. And you can see it in the tricep as well as in the axilla. And on the basis of that, we felt that, well, it's a Ewing's. He's not going to do well. It's locally recurrent disease. So we'll just give him radiotherapy, treat him symptomatically. And then a year later, he survives and the axillary mass increases. And we say, well, he's gone a year. The survival of these sorts of things is usually about 2. So in 2 years' time, he's still alive. He doesn't have pulmonary metastases. And he now has an axillary sarcoma that's fungating through. And you can see it there. This was just last week. And he says, can you take my arm off? And up until then, he had said, no, I don't want to take my arm off. I want to keep my arm. And if I'm going to die, I'll die with my arm on. And so we elected to go down that path. But the most recent MRIs now show that where the subclavian comes over the first rib, he actually has a recurrent nodal metastasis there. So, really is quite interesting in that PET scan that we have shows abnormality down his left knee. That's in fact PVNS. He's unlucky enough to have PVNS around his knee. That's not Ewing's. But you can see it really is quite loco-regional disease of recurrence rather than visceral disease. And so, the question is, 2 years down the track, almost 3, do we invoke palliative surgery or do we attempt curative? So those are the questions that we would ask. In terms of unresectable disease, then palliative second-line chemotherapy is what the fallback we usually have, and we give more radiotherapy. But I think with the advent of particle therapies, particularly carbon ion and proton, there's been a real change in the mindset as well as algorithms of how you might treat. And our colleagues in Japan really have been the absolute forerunners in this. And we collaborate very closely with our colleagues in Chiba, Dr. Imai and Professor Kamada, who really support a lot of the carbon ion therapies that we prescribe for our patients. And in Gunma, Dr. Kaminuma and the team there have also supported us at the time when the Chiba machines were being serviced. And what we've found is really quite considerable response from them. If I can just give you these 2 slides. In 2017, this is just an example of the efficacy of this. Patient with a huge chordoma elected not to have surgery for that. And so we sent him off to Tsuchiya, and in May of this year, he had a MRI scan, and that's what it showed in terms of sustained control of disease. So with that said, planning, as we heard earlier from Bhavin, investigations and how you might choose to use those really, really important. This is a person I operated on in 2005 with a osteosarcoma, presenting 16 years later with this heterotopic bone. And the question is, what was it? Patient had an infection and loosening and had been revised about 10 years ago. Was this related to that or not? The 2021 functional scan there is a PET scan showing increased uptake, has been biopsied on 3 separate occasions, and all occasions demonstrate that this is just heterotopic bone. Interestingly enough, there doesn't seem to be any provocation of that heterotopic bone, and yet it seems to be increasing in size. Every time you image it on a yearly basis, it seems to be getting bigger. And I just wonder where this is all going to end. They are rare, as Manish said right at the start. And so, relying on MDTs, this is one of our MDTs. We have it on Wednesday mornings. And we have our plastic surgeons in with us as well here, and a whole bunch of others, about 20 of us. These days we do it by Zoom now because we're not allowed to have that many people in one room anymore. But the good thing is networks such as this allow us in Australia here to poll all our colleagues around the world for opinions. And that does, I must say, it's one of the things we, as the ISOLS group, do, and it's certainly something that I've benefited from talking to my colleagues. So what about the decision tree? At the end of the day, philosophically, you got to ask yourself, can you really cure a recurrence? What do the numbers actually say? So you have to take a path that looks at curative or palliative, and what that means is how aggressive should your treatment and indeed surgery should be. And for us as surgeons, we feel an obligation to operate sometimes, but whatever it is, I always pick the simplest path. I've always been taught to keep it simple. And I rely very heavily on the life expectancy. A good medical oncologist with experience will tell you honestly what they feel the life expectancy is. A slightly inexperienced medical oncologist who would like to appear very experienced will go on forever but not able to tell you how long the patient has. And you can see there that amputation is on the cards for whether it's less than 3 months, 3 to 6, 6 to 24, greater than 2. And those are the 4 categories of times that I look at, because what I do is for each incremental improvement in life expectancy, I get a little bit more aggressive with the surgery in terms of what I hope to achieve. I think in major centers, if you are going to go to curative, although I do say keep it simple, there is the capacity and the skill base to at least make it a functional recurrence. What to prepare for? Scar, and more scar, vessels and nerves. And Frank is going to tell us how to sort of play hopscotch on the minefields, particularly in the pelvis, such as this case where you go in, you're told that, this should be pretty straightforward, just do a hemipelvectomy. Well, when you're operating through concrete on the inside and someone doesn't tell you about the femoral crossover graft that they have in the way, and before you know it, there's blood splashing all over the shop. Particularly if you're invited in on a case, it can be very interesting. And this is where multidisciplinary team support is really important, and also getting the opinions of people. I think being very, very careful in decision making is probably the most important thing for patients. And then at the same time, ensuring the patient and carer support the decisions that you make. So I finish by saying, if I have any advice for anybody, it's to say that it's really not for the faint-hearted. Thank you.
Thank you, Peter. I think you really brought out the issues, and I completely agree. It's more of a philosophy than really what can be done. And I think the patient is probably the most important factor in deciding how much you should do. And as you said, I think pelvis is even a bigger challenge when you're looking at recurrence, because the primary itself has been a challenge. And what do you do when you get a recurrence? So I think we're going to look up to Dr. Sim to give us some idea of how to manage a local recurrence in the pelvis. Over to you, Dr. Sim.
Yeah, thank you very much. It's nice to see everybody. A little early here in Minnesota, but other than that, are my slides up? My slides are up, okay?
No.
No? Are they up now? No?
No, not yet. Yeah.
Yep.
They're up now?
Yep.
Okay. So this will change them here. So anyway, it's obvious that tumors in the sacropelvic area are very challenging, but the challenge is really magnified when the patient presents with a recurrent lesion in this area. And there's very little written about management or outcome of patients with recurrent tumors in the sacropelvic region. Hit here. Okay. So in this presentation, we'll review some of the prognostic factors involved with local recurrence, some treatment concepts, what's known about the outcome, as well as review some of the advances in new paradigms that have been carried out to improve the outcome of these patients and hopefully minimize recurrence. This shows the challenge in sacropelvic tumors. Their pelvis is not well compartmentalized. These tumors can grow to very large size before they're recognized. They can cross the sacroiliac joint, involve vascular structures, and it's difficult to achieve clear margins many times because of the relationship to the viscera. So of the risk factors, the tumor type, as Dr. Choong has mentioned, is important factor. And of the three major tumors involving the pelvis, osteosarcoma remains the tumor with probably the worst prognosis. This is a study by Bruno Fuchs a number of years ago, and in that era, the outcome was 5-year survival was about 50%, local recurrence 30%. So, well, these were probably the best results reported then. The result today is still pretty poor. Now, while Ewing's and OGS are impacted by adjuvant treatment, we're going to concentrate primarily on sacropelvic chondrosarcoma this morning because that relies primarily on surgical margins to achieve local control. So this is a recent interesting collaborative study with the Toronto group and the Mayo group, which looked at risk factors in pelvic chondrosarcoma. In that study, high grade and dedifferentiation impacted poor survival. They found that age was important, particularly for low grade and intermediate tumors. Those patients with a soft tissue mass had more adverse outcome. The surgical margins and the grade impacted local recurrence, and local recurrence in turn impacted survival by upgrading the biological activity, becoming a higher grade, and with the aggressive biology, put the patient at risk for metastasis and death. Now, this is an interesting study from Mayo a few years ago by Maya Pring and Christy Weber. They looked at 64 patients. 51 in that group had limb salvage, 13 had an amputation. Local recurrence was 19%. And metastasis 17%. And those are figures that have been reported in current era as well. But in that study, the marginal resection had a strong influence on local recurrence, and the grade of the tumor impacted overall survival. As I mentioned, there's very little written on the outcome of patients who require further treatment for recurrent pelvic chondrosarcoma. Christy Weber reviewed 21 patients, and of that group, 18 had grade 1 or 2 lesions at the time of recurrence, and 3 were high grade. The mean time to recurrence in the pelvis was 27 months, but patients in this area require long-term follow-up. Despite efforts to achieve good margins to prevent recurrence, 70% had a second recurrence. And of those, there's increased tumor grade in 9 of the 21 patients. There were 3 at the index recurrence and 6 subsequently. And because of local involvement, generally these patients required more extensive surgery to achieve clear margins. 62% in that series underwent amputation. This was compared to 20% in our primary series. Complications, you can see, were higher in that group as well. So I have 2 cases I can show you that I remember well. Peter Choong probably did this case, but in any event, I can blame the patient for the recurrence here. And we all have patients like this that like to dictate treatment. I think all of us would feel that this is a curable low-grade tumor. And if he had to follow our advice to do a P2 resection with adequate margins, but he was more concerned about his function, so refused. So this was carved off, including the inner wall of the acetabulum, and did well for 3 years, but he developed this local recurrence at 3 years, requiring quite an extensive internal hemipelvectomy. And then, unfortunately, he developed a second local recurrence at 8 months and had this very extensive external hemipelvectomy and died of metastasis. I think I can take the blame for this one. This patient has a small lesion from the anterior acetabulum, intermediate grade. So he had a partial acetabular resection with a total arthroplasty, but had recurrence at 11 months. So at that point, he had an external hemipelvectomy and remains free of disease a number of years later. So there have been some advances to improve the outcome of sacropelvic tumors with improved staging. We have better patient selection for the procedure. And I think this will be discussed later, but there's more clear-cut indications for the role of amputation when necessary to achieve clear margins. And moreover, there's more sophisticated planning with 3D imaging to provide better accurate margins. We found these 3D models to be very valuable in showing the surrounding structures and planning sophisticated complex resections. The model in the lower right is recurrent lesions. The different shades show the extent of both interosseous and extraosseous recurrence. It's illustrated in this patient with very extensive involvement of the anterior pelvis with a chondrosarcoma. And you see the value of the 3D model in demonstrating the relationship to the surrounding structures, plus involvement of the pelvic viscera. It also helped multidisciplinary collaboration among the various disciplines that are required to remove this tumor with clear margins, including the pelvic organs. In the sacrum, the outlook has been very dismal in the past as well, with a high incidence of local recurrence, which adversely affected survival. But there are a number of studies from several institutions that demonstrated the importance of achieving clear margins in order to provide local control. And because of these articles, more extensive surgical procedures have been developed to predictably achieve clear margins and local control. And what's enabled us to do these is development of better reconstructive methods to restore stability and function. First, this is a pretty standard chordoma. He required a total sacrectomy and had reconstruction with a standard posterior construct, but also vascularized fibulas extending anterior to restore the anterior sacral arch. And studies in our lab show that this provides twice the resistance to failure. We've had several patients that have failed proton beam radiation. And here you can see the importance of the 3D model in planning this complex resection. showing the vascular involvement. So with the sophisticated planning, we were able to achieve clear margins and reconstruct, restore stability. Sometimes the resections require complete removal and loss of continuity between the sacrum and pelvis. And in these cases, we've utilized the proximal femur from the amputated leg to as an intercalated graft to restore stability. And of course, the mother of all resections is a hemicorpectomy, but fortunately, this drastic procedure is not required very often. But it was necessary here to achieve clear margins. And this patient with very extensive involvement, and she had an L2 hemicorpectomy. You see, she had to lay in her stomach most of her time, and she's done very well, healed up, and is now more than 2 years and doing well. So recurrent sacropelvic tumors are very challenging. The outcome is worse than in more distal lesions. And it's very difficult to achieve tumor-free margins. So in this area, it generally requires more extensive surgery. And local recurrence is to be avoided. The first operation to have a chance of local control is the most important, because with recurrence, you see biological upgrading with risk for metastasis and death. In our series, 50% of patients with recurrent chondrosarcoma achieve long-term survival. So I'll turn it back to Manish.
So I don't know if there are any questions. I don't see any questions on the chat. So if
No questions, Manish.
so, I think we'll just begin the panel discussion by asking all our panelists who've got extreme experience in managing this. I mean, how do you take a call on whether this is going to be a curative resection after local recurrence? As Peter said, that you need to decide whether it's going to be curative or it's going to be palliative to decide how much needs to be done. And how do you take that call? I mean, is it just going to be dependent on whether you can resect it completely with a margin, or it's also going to depend on whether you're going to give them adjuvant chemotherapy or radiation? How do you decide?
Maybe I can start off.
Okay, you can start, Peter.
So Manish, I think the two things that go through my mind. First of all, when you're dealing with things like this, I often rely on the numbers. So what does the evidence tell us about this type of case? Because, you know, all of us are, well, everyone on the screen is far better than me in terms of experience. And what I can say is that the capabilities of surgery is extensive today with 3D printing and robotics and all the rest. We can do almost anything we choose. But the question is whether we should or not. And I rely very heavily on the evidence of survivability for that patient. And if I felt that the numbers would indicate that the patient had a significantly reduced survival, that would very significantly influence or inform my decisions as to what I would do to a patient, even to not do anything. You know, so I think that's probably how I've recommended it be approached, is find out what the survival is.
I think that's a really good point. You have to look at the overall patient status, because as Dr. Choong says, technically we're getting better and better, but our indications still have to remain strong, because just because we can do something doesn't necessarily mean we should do something, especially if the patient does not have a very good long-term prognosis overall. So I really think that you have to look at the overall kind of status of the patient and then go from there.
So I could make a comment here to support Val's point. I think we're doing better with patient-reported outcomes. The Sacral Tumor Study Group has a strong interest in this, with the major resections in functional evaluation and patient-reported outcomes. We did a series with our colon rectal surgeons. I know Toronto has a large experience in this. And we looked at about, 11 or 12 or more extended resections for recurrent anal rectal cancer. And we looked at it with patient-reported outcomes. But the one most important question we asked, would you do it again? and everybody except one said they would do it again. So I think we're learning more how to evaluate these patients to determine their outcome and whether it's worth it.
Yeah, Manish, it's Shay. So, I mean, everyone has touched on this in their talks, right? Patients with recurrence and metastatic disease are going to fare pretty poorly. And a lot of it has to just do with biology, right? What's the histology? What's the disease-free interval? What kind of adjuvant therapies were used initially that they failed? And, is this a recurrence due to, poor resection, or is it really a biologic recurrence that's despite a fantastic, resection and great margins, that's worse. And what adjuvant therapies are available is the other issue, because if somebody has a recurrence and they fail their initial treatment, it's going to be more difficult to get them to a curative state. I mean, generally, if they have, somebody with localized disease, the goal is to try to provide curative therapy for them if it's reasonable and they can be potentially cured. And, it's not common that somebody's going to have a local recurrence with isolated disease, especially if there's a reasonable disease-free interval where you're not going to attempt to achieve local control. Now, again, there's always amputation, but, we're always trying to provide, limb sparing or better function. But, a lot of this is just, as everybody's touched on, is biology, and that could be, histology, grade. Is there a change in grade and disease-free interval? And those are really important factors in terms of what the outcome's likely to be. But, every single patient's a little different in terms of what adjuvant things can be used to help downstage it or, improve the margins that you're able to achieve, and how improve your ability to provide disease control. So it takes a big team effort when there's a local recurrence.
So I'm going to put a specific question. Let's say it's an Ewing sarcoma in the extremity. You have a local recurrence which looks resectable. The patient has had a good response to chemotherapy first time around. The recurrence has come in 2 years after surgery, and there's no metastatic disease. How do you approach this? I mean, would you always start with second line chemotherapy, wait for it to respond, and then plan the surgery? Or would you do the surgery first since it's a resectable disease and then put the patient on adjuvant therapy? Or would you use radiation alone for the local therapy because it's a recurrent disease? Because we know that Ewing's is particularly bad when it comes to a recurrence.
I think, Manish.
Yeah, Eduardo.
Yes, I think if the local recurrence is isolated and I can get the wide margin, I will be very aggressive in that case. I would like to go to the surgery. Anyway, always putting in all the table the multidisciplinary team together to see what's going on. But in the biology, we are talking about Ewing sarcoma, we are talking about osteosarcoma, and what type of tumor we are talking. However, in generally, if I can do the wide margin, I will go.
But
Dr. Grimer, Jay?
Yeah, so Ewing's so just like the paper for Peachy that Peter talked about, for osteosarcoma, where margin and necrosis heavily influence your local recurrence risk. The same is true in Ewing's, and John Healy and I did a paper that showed that pretty convincingly. So in a disease that typically is chemosensitive, just like osteosarcoma, I mean, it would make sense to take advantage of every, neoadjuvant or neoadjuvant opportunity that you have up front, to downstage the tumor, so it's more operable and to improve, that it can lead to a better margin and also better necrosis, right? Because better necrosis up front is going to help resectability. And if they've had a good response to initial chemo, why go to second line chemo, right? If they've had a good response to initial chemo, you could go back to the same chemo and hopefully achieve a similar response. And again, if they have, if they show evidence of response to chemo after 1 or 2 cycles, then they can get a whole course of preoperative chemo with first line therapy. And only if they don't respond to first line chemo, maybe would you need to go to second line chemotherapy. But, a disease that's known to have chemo sensitivity, there's so much benefit from trying to take advantage of that, because you know that whatever margin you get may not be adequate in a recurrent setting compared to a primary setting. So you really need to use everything. And then, so listen, there's a whole controversy about radiation for extremity Ewings, and we use it rarely. A lot of people use it a lot, but in a recurrence, I think depending on what margin you get and what necrosis you get, you may need to consider that as well, right? Because it's such a difficult situation to control.
Dr. Tsuchiya, how would you tackle it in Japan?
You asked the treatment of resectable recurrent Ewing sarcoma, is it right?
Yes,
okay.
Yes, correct.
We usually perform chemotherapy because we want to know the effectiveness of anti-cancer drugs first. If then we do wide excision if possible. Margin is negative, just it's done. But margin is contaminated, we add radiotherapy over there. But if preoperative chemo for recurrent Ewing sarcoma is not effective, probably prognosis is not so good.
I'm going to now show a case. Okay, this is a 14-year-old girl who had an osteosarcoma. It was in the diaphysis. We did an intercalary resection after preoperative chemo. She was a very good responder to chemo. She had more than a 90% necrosis. We've gone in and done extracorporeal radiation and reimplantation. Whatever soft tissue she had, we sent that for histopathology, and it said that there was no viable tumor. A year from her surgery, her proximal junction had not healed, so we bone grafted it. And then by 2 years, she had good union at the junctions. At 65 months, she came with this soft tissue swelling on the thigh, on the distal thigh. It was on the medial side. How do we approach this now? It's more than 5 years since her surgery, no metastatic disease, and she's got a soft tissue swelling in the thigh. These are the X-rays. It does not look like the bone is involved. So how do we go about it? Dr. Dreimer would like to answer.
It's very unusual to get a local recurrence this far down the line. And you've got to go back to first principles and get some imaging, probably with an ultrasound initially, and then follow it up with some of the excellent imaging from Bhavin to see what it shows. And luckily, there's not too much artifact. And you're going to take a biopsy of that and see what it shows. But it looks very much like a recurrent osteosarcoma.
Yes, you don't see any bone formation on the soft tissues on the X-ray. And this is what the MR is looking like. It looks like it's sitting on the surface of the bone, like the previous tumor. And it looks like it's away from the neurovascular bundle. So should we go down and resect it now? I mean, the question to the entire panel. And what kind of margin do we expect on the bone? Yeah. And it's going to be just a periprosthetic membrane. And is that going to be a good enough margin for this? Well, or should we really think of an amputation here?
Well, I think you've got to, I know we would give further neoadjuvant chemotherapy and see how it responds. We treat it just like a new primary tumor at that time down the line. And then you get some post-chemo imaging.
I think sorry, Rob.
Lee?
No, I was just going to say for the audience, I think the important thing at this stage is to restage the patient, isn't it? So you need.
So we did that. We did a PET CT, and it's non-metastatic.
Yeah.
and this is the only site of disease, and it's not in the bone. There's no activity inside the bone, even on the PET CT, and the MRI is showing that this is a soft tissue mass. Now it's on the surface. The neurovascular bundle seems to be clearly away from the disease.
Manish, is it mobile or fixed to the femur?
It looks fixed. I cannot move it away. It's not mobile.
Yeah, so
it looks like it's adherent to the periprosthetic or that ECRT bone. But it's not, there is no involvement of the bone.
Yeah, I think if it's fixed, it's going to be very difficult to sort of take that off subperiosteally and get a reasonable margin. So I think you have to be prepared to resect, your intercalary segment, depending on the proximal and distal extent. And then depending on what you have available at your center, putting in allograft, or if it's too far proximal and distal extent, then potentially having to do a total femur prosthesis. But I would not try to peel that off the femur.
And would you give chemotherapy first, Peter?
Yeah, yes, I would.
Yeah, for sure. 5 years later is really late. And so I think you're right to consider that just as a new primary in terms of chemo treatment. But there won't be periosteum on this the way there might be on a regular femur. And even for a regular femur, if that tumor was fixed to bone, I think you'd be pretty hard pressed to accept like a potentially microscopically positive margin to save the bone in a setting where there's been a recurrence. So for sure, I think to be safe, you'll have to resect that segment of the allograft and then think about some form of either intercalary reconstruction or total femur reconstruction. But if you've been able to save the proximal distal ends first, and this is in the middle of the femur, maybe you could still do the same type of reconstruction again, or add a fibula even, depending on if it's long enough to span that defect.
So if we're going back to first principles again, as we said, this is a late recurrence and a good responding tumour. And therefore you've got to be aggressive with this, haven't you? So you've got to treat it like a new primary and try to get as good a margins as you can. And I think when we were talking before about how we make the decisions, it goes on the biology, the response, and then the time to local recurrence is also very important. If you have a D. diff chondrosarcoma and it comes back within 3 months, then you know that that's very, very bad news. But this is a late recurrence in a previously good responding tumour in a young person, and therefore you've got to be aggressive with it. Yeah.
There's an international question from Dr. Gaston, who asks, what's the panel's threshold for performing rotation plasty for recurrent tumours with a poor prognosis? And it's probably a good opportunity with a case like this, if it wasn't possible to do an intercalary re-resection, about whether it's an option.
So it goes back to philosophy again, doesn't it? So if you've got no signs of metastatic disease in this patient, and you're going to be as aggressive as possible, as Frank talked about earlier, unfortunately, you've got to involve the patient in the decision making. But your advice has got to be that you've got to get as good a wider margin as possible on this tumour. So then it comes down to the patient, and a rotation plasty in this situation would be a good option for this patient with an intercalary femoral disease. Means you get completely wide margins. And so it comes down to the patient.
How old's the patient, Manish?
24.
Yeah. So she was 14 when we did her first. She's now 19 years old.
So it really just depends on what your ability is, what kind of margin you're going to be able to achieve, and what her functional status, she would accept. And what reconstructive options are there for her. If she's very happy with, this intercalary resection, the only problem with doing another intercalary resection is she's obviously going to be much weaker, because you're going to have to resect quite a bit of the residual quads, right? Maybe you can save rectus, but you're going to have to resect half of the medialis and half of the lateralis, and so her quads function will be less. And so even if you can save the proximal distal femur and reconstruct it with another allograft or with a vascular fibula or prosthesis or whatever, she'll be less strong. Whereas, if she's very, interested or wants to be involved in sports or higher level function, sure, there's rotationplasty could provide a better margin and maybe better function in some ways, but that's the trade-off that the patient has to accept. But in this case, you could certainly achieve a really substantial margin if the tumor stops growing, or even if there's some response, you could certainly achieve a negative margin resection in this case. And then it really just is a matter of what's the patient willing to accept and what options are available to you for your.
I think that's a really good point, Jay. I think it's something that has to be discussed with the physician, but also with the patient, because really an amputation or rotationplasty, you're going to have a better margin. I mean, even if we can get a, quote, negative margin that we're taking it off and redoing an allograft, removing that tissue entirely will give you a better margin. So I think if you have a patient population or a group of patients who are successful with a rotationplasty, I think that is very helpful in convincing patients or making them more comfortable with that choice. I actually have a patient who's going to the Olympics with a rotationplasty this year, and she's been incredibly valuable in talking to other patients, showing that they still can lead really active and successful lives with the rotationplasty. So I think as orthopedic oncologists, we can't forget that amputations and rotationplasties can really give the patients very good functional outcomes, and they just need the support network both before and after the surgery to help them with that.
Now, I have one question to the entire panel is that, let's say this was not a recurrence. Suppose this was a soft tissue sarcoma sitting on the bone. Let's say it was sitting on the periosteum and still not mobile. We would have probably done a preoperative radiation, and then we would have taken it off, accepting the periosteum as a margin. Can we do the same thing here?
Well, there's no periosteum.
You have a good periosteum on an allograft.
Right.
No, it's not an allograft. It's a ECIT, which is like an allograft, but there's always a membrane. I mean, we've always seen that there's a bone membrane which forms, and you can generally peel this off from that bone. But the margin is small. It's a marginal margin. It's not a wide margin.
I think one of the differences, though, is that we know that a micropositive margin in osteosarcoma is really bad in terms of predicting local recurrence, and especially in a recurrent situation. And if you look at the soft tissue sarcoma data, like our data from Kenny Gundle's paper with that, Toronto margin classification, when we do pre-op radiation and we achieve, try to get a close margin to, let's say, save a nerve or a bone or a vessel, and you take the periosteum or the adventitia or the epineurium, we showed that even with a microscopic positive margin in that setting, the local recurrence rate is pretty close to the negative, a resection with a negative margin, but that's it's different disease in soft tissue sarcoma. So you can, in those, accept microscopic positive margins along these fixed structures with pre-op radiation. But the translation to recurrence is low in that setting, but is very high in osteosarcoma. But that's for primary, right? That's generally for a primary resection. And so, it's very different in osteosarcoma, I'd say, in terms of your resecting a recurrence and what's satisfactory to avoid local recurrence. And the other problem, again, is, you can give them chemotherapy, but you never really know the response to that chemotherapy until the tumor is resected. So in a recurrence, you really need to be certain that the margin's negative. I don't think you can leave it to chance with a millimeter or so in terms of trying to save a bone that's, probably not worth saving.
But it just comes back to what we were talking about before, though, isn't it? That we're talking generically about sarcomas, but actually everything's very different, isn't it? So a late recurrence in a previously good responding osteosarcoma, that's a salvable situation, where in terms of patient survival, whereas a recurrence in Ewing's carries with it a much worse prognosis. So I think this is what you're going to treat the two cases differently. For me, this case needs a wider margin as you can get, because the chances are the patient can be cured by the correct surgery.
I think actually there are similarities between the recurrence in this scenario as well as treating the primary, and that is, I think literature does show that the most complete margin is the one that is associated with the longest survival, and this is particularly so in recurrent disease. So let's say, for example, the biopsy was done and that was shown to be a recurrent osteosarcoma. We hadn't actually got a biopsy when we were discussing before, but it were a recurrent osteosarcoma, say, and we wanted to give this patient a curative intent, then I think we would have to accept that the widest possible margin is what we would need. And I think the widest possible margin would still allow limb salvage surgery, be it, a new intercalary bone or a total femur or even a tibial turn-up, something that I've done since the experience at Mayo. And it really goes back to the philosophy of what we're trying to achieve in terms of cure or palliation.
So what we did was we took it off because she was not willing for a major intercalary resection, and it came off. It came off quite easily from the bone. I mean, it peeled off with the membrane. And what we were surprised is that the pathologist never found any osteoid or new bone in it, and they called it as a synovial sarcoma. They asked us whether this is a soft tissue sarcoma. So we just took it off. Although we knew that the previous histology was an osteosarcoma, this didn't show on histology.
Did you biopsy that?
Manish,
Did you biopsy that?
Yes, we did a biopsy, but on the biopsy they just said it's a high-grade sarcoma. They said that we can't say it's an osteosarcoma, so we went ahead and removed it.
Okay.
And was that molecularly confirmed as synovial sarcoma with the translocation?
No, it wasn't. It came negative for the translocation. So we knew that this is probably something different because this is an osteosarcoma, considering that previously she had an osteosarcoma, but we could not demonstrate any osteoid or any bone formation in the final specimen.
So this man needs a genetic studies because has two high-grade sarcomas in 5 years, osteosarcoma and synovial sarcoma. That is very interesting.
Yeah. Now, 10 months later, she got another recurrence, and this time it was on the lateral side. It wasn't on the medial side where she was operated from. And it's all on the lateral side. This one is over the plate. This one is a little mobile compared to what it was before because it looks like this is moving over the plate. And again, you don't see any bone formation here on the X-rays. And we did an ultrasound, and an ultrasound showed again that the vessels are again away from the tumor. So again, the same dilemma: how should we treat it now? Should we do an intercalary resection now, or considering that this is sitting over the plate, this is not over the bone? Should we go ahead and just remove the plate and still get a margin and just take it out and leave the bone as it is because it's healed on both sides?
Manish, did you give her radiotherapy after the excision of the synovial sarcoma?
No, we did not, because we were worried that it will cause a fracture again, because she's already ECRT bone radiated, and I was a little worried because there was very little soft tissue now left on the medial side. I mean, we did it as a resection, and we thought that we'll just observe her for some time because we didn't even get a diagnosis of an osteosarcoma on the final pathology.
What was the deep margin of your resection? Was it not very close?
It was close, but it was clear of tumor.
That's pretty brave for recurrent.
They said it's about 1 millimeter. It was a millimeter margin, so which is a very, very close margin.
I mean, usually that's okay after neoadjuvant therapy, but not without neoadjuvant therapy.
Correct.
You're a far better man than most of us, I think.
No, I think we did not have enough information. I mean, the patient was not willing for a major surgery, so that's what was a big problem.
I think the writing is now on the wall, Manish.
Pardon?
So that was like Frank's case where he said the patient refused the right operation, so it's all on their shoulders. Except they still come back to see you.
I think we are to blame if we accept that option.
Yeah, it's the patient's fault.
One of the
Here again, I removed the plate because the screws had anyways broken, and we removed the plate, and the tumor came off very comfortably as we removed the plate. And again, we had a good margin. But this time, the pathologist did tell us that this is an osteosarcoma. And within 6 months,
Surprised you didn't put a new plate on. Like, I would never leave an allograft without a plate.
It's not an allograft.
Yeah, I know, but it's like an allograft. It's been radiated.
It's dead.
Yes, but putting a new plate would be very difficult with those broken screws.
The patient continued without metastasis at this moment?
No, there was no metastasis.
I think, I don't know if it is the point to think about amputation. What do you see the rest of the team?
So at this point, when she came in with the path fracture, this time when we did a PET CT, there were 2 lung nodules which were metastatic, but they were resectable. So the question again now is an amputation versus some palliative total femur.
Yeah, but your situation has changed now, hasn't it? You've got to...
Correct. Now we can't avoid major surgery. I mean, we have to do a full resection here.
But also in terms of biology, situation change. You've got 2 metastatic.
Yes, we've got metastatic disease.
Which may be resectable, but that heralds very bad news.
Correct.
We know that pulmonary resection at the time of treating the primary, according to the Germans, has a good outcome, but in a situation of a twice recurrent tumor.
There's the truth. That's the truth.
There we go.
Amputation. No way. Palliative amputation. This is horrible.
Yeah. Agree.
So it begs the question whether an amputation should have been done with the first recurrence, and then she would have been functional for longer, and perhaps without meds.
But would she have
I think the mistake made is that we did not give her chemotherapy again when she was a good responder first time around. The second mistake was we accepted a resection with very close margins. We shouldn't have. I think correctly said, we should have done an intercalary complete wide resection with again reconstruction if we wanted to do limb salvage, or we should have done a rotation plasty first time around, getting a good, nice wide margin. Maybe that's what we learned from this. And I think this was potentially a curative patient, which I think as because of the repeated recurrence, I think we pushed her into metastatic disease.
So hindsight is an exact science. Yeah.
Yeah.
It's always easy to look back at the end and say, yeah, what we should have done. But I think the case shows for the audience quite a lot of principles. Yeah. Now, whether she would have got metastatic disease at the end, who knows? But I think that's the important point, that second-line chemotherapy is important because that's what tries to reduce the risk of metastatic disease, and then better local control. Because if we look back and see what's happened to this young lady, she's had now 3-4 operations, all with the recovery time. And even if she's survived for 4 or 5 years, during that time, she spent a lot of time in hospital or recovering from operations. So I think the principle again goes back to right diagnosis at the beginning, followed by systemic therapy for things that can have systemic therapy, and then as radical surgery as possible. At least we should advise that for the patients, and then the patients should decide whether they want that. But I think our advice should always be for what, second line chemo, and then as wide a margin as possible.
Do we have time for another case?
No, we're on time already, Manish.
Manish, I have a question. It's okay?
Yeah.
This is a recurrence from irradiated bone, probably.
Correct.
Right?
But it's not. It was not in bone. It was a soft tissue. But
not soft tissue from the bone. No, from the bone.
No, it wasn't in the bone.
It
wasn't in the bone. Even when we removed it first time and when we removed it second time, it was never in the bone. And after that, she got another recurrence, and then she had a fracture. So there was no tumor, no disease even in the bone, even at that time.
But what's the recurrence rate when you apply recycled irradiated bone?
Well, the recurrence rate is less than 10%, but it's almost always in the soft tissues. I mean, we've never seen a recurrence inside the bone, inside the radiated bone.
It depends on surgical margin, not irradiation.
Correct. So most of the times the recurrences that we have seen are soft tissue recurrences in the margin.
Right. How much dose do you use usually?
We use 50 gray. 50 gray.
50.
Yes, 50 gray. So it's 5,000 rads given immediately. I mean, it's given over 20 minutes.
Okay.
They first give it from one side, then they turn it over, and then they give it from the other side, and that's been effective for the last 15 years that we've been doing this.
Okay, thank you.
So I think we'll have to just sum it up now since we are out of time, and I think the principles again that each case has to be individually evaluated. We have to look at the adjuvant therapies, and we have to use them even when we have a recurrence, and then think of a curative resection. And I think the most important thing that we learned from that case is that we can't compromise the margin, particularly in recurrence, and we need to get good margins, and then only we can think of giving the best chance of cure for that patient.
Yes.
Any other comments? Dr. Grimer?
I think you've summed it up beautifully, Manish. There's no doubt the principles we were all taught 50 years ago, that the first bite you get at the cherry is the most important one, and get clear margins the first time if you possibly can.
I might make this opportunity. It's a good segue into wrapping up this evening. I mean, thanks very much, Manish, for chairing a marvellous session, and to your international panellists. This was the 9th seminar, and we've got seminars scheduled all the way through to March next year, just about 8 weeks preceding the meeting in Los Angeles. The next seminar in August is going to be about paediatric benign bone tumours. We've got Doris Winger, from the radiologist from the Mayo Clinic, giving us a rundown, and then Sevan Hoppy from Toronto is going to speak about various bone grafting options in children. MJ van der Sand from Leiden is going to talk about various injection modalities for aneurysmal bone cysts, and Professor Tsuchiya is going to talk to us about his special technique for simple bone cyst treatment. So we look forward to seeing you all with a less contentious topic in the next month, and thanks very much for your involvement this evening and for everyone who attended. Thank you.
Wow.
Thank you, guys. Thank you. Thank you. Thank you all of you.
Bye.
Nice seeing everybody.
Bye-bye.
Thanks, Manish.
Great job, Manish.
Thanks, Manish.
Bye-bye, everybody. Bye-bye.
Bye.
Thank you. Oh.